Good morning, good afternoon, and good evening to everyone. I'm very pleased to be a moderator for this free paper session on epidemiology. We have really interesting presentations from speakers from the UK, Germany, and Sweden for this session. My name is Dr. Siobhan Masterson. I'm currently the National Lead for Clinical Strategy and Evaluation with the Irish National Ambulance Service. I've worked for many years as project manager for the implementation of the Irish Out-of-Hospital Cardiac Arrest Register and on the development of the Irish Out-of-Hospital Cardiac Arrest Register strategy. And I'm also part of the study management team for Eureka and a recent fellow of the ERC. It's my real pleasure to introduce our young ERC investigator, co-moderator, Dr. Franziska Wagner, who is a pediatrician working in Leipzig in Germany. Franziska already has an impressive list of peer-reviewed publications, particularly on the topic of pediatric cardiology. She's been responsible for the in-house research training of the Heart Center Leipzig for the past 5 years, and she's also involved in setting up a multi-center observational study, which will investigate resuscitation outcomes in pediatric cardiology, and that starts next year. It is always my pleasure to share the moderation platform with my friend and colleague, Professor Jan Thorsten Graesner. Jan Thorsten has been a physician for 20 years, and he's currently the director of the Institute for Emergency Medicine in Kiel. Among his many achievements, he's a senior member of the German Society of Anesthesiology and the German Resuscitation Registry, and he's a member of the ILCOR BLS and ALS working groups. In his spare time, Jan Thorsten is the primary investigator for Eureka and has been the author of over 160 peer-reviewed articles. How we'll do things today is that Franziska will introduce each speaker before their pre-recorded presentation will be played. We'll take questions from the audience on each presentation directly after their presentation is played. We do have quite a lot to get through, so we may not be able to address all the questions live. So please keep an eye out for the speaker's contact details if you want to question them further after the presentation. So Franziska, may I ask you to present our first speaker, please?
Of course. So our first speaker will be Johan Israelsson, who is a PhD cardiac nurse and resuscitation coordinator from the Kalmar County Hospital, and will speak about the topic of self-reported health among cardiac arrest survivors.
I think we're just waiting now for the pre-recorded presentation to be played.
Right, yeah. Okay.
Dear audience, I would like to welcome you to this presentation of our abstract, Self-Reported Health Among Cardiac Arrest Survivors, Broader Perspective Using the Health Index. My name is Johan Israelsson. I am a PhD cardiology nurse and resuscitation coordinator from Kalmar in Sweden. Also, I do a lot of work for the Swedish Resus Council and the Swedish CPR registry, especially regarding post-resuscitation care and patient-reported outcomes. According to the COSCA guidelines published in 2018, health-related quality of life is an important outcome in cardiac arrest survivors. And in general, the survivors appear to have acceptable health and similar health compared to general populations. However, specific and validated measures are missing, and most studies have reported limited aspects of health, often based on composite scores of general, physical, and mental health. Consequently, there's a lack of knowledge of specific health problems among survivors, making it difficult to develop interventions and be able to offer evidence-based support. So the aim was therefore to present a more comprehensive description of health problems reported by cardiac arrest survivors. And this is some preliminary results from a cross-sectional multi-center study. We included 212 adult cardiac arrest survivors. Most of them were men, and most of them had suffered an in-hospital cardiac arrest. We sent the participants a postal questionnaire at 6 months after their cardiac arrest, and this questionnaire included a health index. And the health index is a broad measure of self-reporting health. It includes 9 health domains and 2 items about general health. It's also possible to calculate an index score based on the 9 health domains results. Health problems were rated on a 4-point scale from no problems to major problems, and the general health was rated on a 4-point scale from very good to very poor. In this figure you can see the results from the health index ratings, and most problems, regardless of severity, were reported in strength, tiredness and mood dimensions, while least problems, regardless of severity, were reported in mobility, loneliness and digestion dimensions. Overall, the vast majority of reported problems were considered minor or moderate, but the highest prevalence of moderate to major problems were identified in strength, tiredness, sleep and pain dimensions. Using the general health measures, almost all participants reported good or quite good health, and compared to previous Swedish studies of the general population, their overall ratings are similar to the general population. So in conclusion, although severe problems were uncommon, the majority of the survivors reported problems in most health dimensions. And to achieve a better understanding of their health, it's important to assess specific symptoms or health problems as a complement to composite scores of general physical and emotional health. Cardiac arrest survivors should be offered the best possible support to achieve a good quality of life. This is one of the overall aims for the Swedish Resus Council, and to be able to reach this aim, I believe we need more knowledge about life after cardiac arrest and specific health problems among cardiac arrest survivors. And the health index appears to be a useful measure to gain more knowledge and be able to improve post-resuscitation care. So thank you for listening, and I hope you have some questions.
Hey, Johan, thank you very much for that presentation. And now let's figure out if this format of online questions will work also in this session. Before we start with a question from a colleague, my first question would be, I really love the idea to see more information about the patient's perspective. But is filling out such a questionnaire a selection? So if someone is in so bad condition that he's not able to fill out that document, will never answer. So maybe you have a positive selection in the group what people are able to answer.
Yeah, I'm sure you're right about that. We have a positive selection in most measures that are patient reported, I would say. So that's a problem that we need to handle. But on the other hand, we have to learn more about the health problems among those in better shape. So I think it's very important to use these measures. And the health index is a very simple measure to use. So I think most patients will be able to use it.
Thanks. And I have a question from Thomas Hermansson. He said, first of all, he said, nice work, Johan. And can we say, this is a question, that a cardiac arrest survivor has good quality of life in general, or only in your study?
I would say they have a good quality of life in general. We see that in our national registry as well, that the majority, when using self-reported measures, they report quality of life as good or at least acceptable. but also there's a huge variation in both the study and in the registry. And of course, it's very important to find those suffering from health problems and offer them support.
Yeah, and hi, Bibiana, a colleague for us from Germany. She asked, did you only include patients with CPC 1 or 2 or also 3? It is a bit like what I asked at the beginning. Can you say something, Johan, about the inclusion of the patient you analyzed?
Yeah, that's one of the major problems and limitations in this study, of course, that we might have included some CPC 3 patients, but not a lot of them. But in our register and this study, the most of patients have CPC 1 to 2, so we don't lose a lot of patients in this study, but of course a few. So that's a major problem. I agree.
Okay, and to keep in time, the last question, short answer, is a question that is dealing with the pain that people report. Do you have any information what kind of pain did the survivors tell about?
No, this measure we can't say what kind of pain. It's pain overall. So, but according to the patients I speak to and according to previous qualitative studies, it's a lot of pain from the chest, from the ribs after receiving CPR, I would say. And I think this is a larger problem that we might have thought. So pain is an important measure, I would say.
Great. There are additional questions, but as we told you before, please address these additional questions directly to the presenter. So I will skip that questions and hand over back to Franziska for the next speaker. And Johan, thank you very much for your presentation and this discussion.
Thanks a lot.
Okay, our second speaker will be Maria Höby, who is a medical student from the working with the Research Center for Emergency Medicine from the Aarhus University Hospital in Denmark. The topic will be in-hospital versus out-of-hospital cardiac arrest, differences in patient characteristics and short and long-term survival.
Hello, my name is Maria and I'm a medical student from Denmark. Today I want to tell you about my project called In-Hospital versus Out-of-Hospital Cardiac Arrest, Patient Characteristics and Survival. Despite few pre-existing direct comparisons, cardiac arrest patients are often divided into two depending on the location of the cardiac arrest. So we have in-hospital and out-of-hospital cardiac arrest patients. This is done based on anticipated differences in patient characteristics, provider characteristics, and timing of interventions. Despite this, the international guidelines for the treatment of cardiac arrests are almost similar. This means that the patients generally receive the same treatment irrespective of the location of the cardiac arrest. Randomized trials primarily focus on out-of-hospital cardiac arrests. This leaves us with a knowledge gap, both concerning the in-hospital cardiac arrest group, but also concerning differences and similarities between the two groups. Therefore, more knowledge is warranted. The aims of the present study was 1. To compare differences and similarities in patient and cardiac arrest characteristics, and 2. To explore whether possible differences could explain anticipated differences in survival. It was an observational cohort study including adults with an index cardiac arrest from 2017 to 2018 in Denmark. Our primary data sources were 2 nationwide registries, and our primary outcome was 30-day survival, and the secondary outcome was 1-year survival. In this table, you can see comparisons of patient characteristics. I have highlighted the ones I want you to notice here on the right. They were not different regarding demographics. In-hospital cardiac arrest patients had more hospital contacts within the past year compared to out-of-hospital cardiac arrest patients. And lastly, cardiovascular disease was more prevalent in the in-hospital group compared to the out-of-hospital group. Here you see comparisons of cardiac arrest characteristics. In-hospital cardiac arrest patients were more likely to present with an initial shockable rhythm compared to out-of-hospital cardiac arrest patients, but the risk difference was small. in-hospital cardiac arrests were more often witnessed by health professionals and also had a shorter time to rhythm analysis compared to out-of-hospital cardiac arrests. These forest plots depict the results from the primary analysis. In the unadjusted analysis, you can see that in-hospital cardiac arrest patients had an increased survival to both 30 days and 1 year. When we adjusted for age and sex and for comorbidities, cardiac procedures, and medication, it didn't change the results. When we adjusted for cardiac arrest characteristics, the entire difference in survival disappeared. This indicates that it's not differences in patient characteristics or in location, but differences in cardiac arrest characteristics that are determining of the differences in survival between these two groups. These results are backed up by our subgroup analysis. We made these in an attempt to create more comparable groups regarding cardiac arrest characteristics. In all the analysis, you can see that the estimates are substantially mitigated compared to the primary analysis. The biggest difference is in the third subgroup with healthcare personnel witness cardiac arrests. So, why is this important? Well, first and foremost, it's important because these results taken together indicate that if we can increase the proportion of witnessed cardiac arrests, or if we can at least try to minimize the time from the cardiac arrest to the initiation of treatment, it can actually improve outcomes for both in-hospital and out-of-hospital cardiac arrest patients. So I have 3 main findings I want you to remember today. 1, these patients do not differ substantially in demographics, in most comorbidities, and in the initial cardiac arrest rhythm. 2, in-hospital cardiac arrest patients have a higher survival than out-of-hospital cardiac arrest patients, also when we adjust for patient characteristics. And 3, in-hospital cardiac arrest patients' increased survival disappear when we adjust for cardiac arrest characteristics and also when we compare subgroups with equal cardiac arrest characteristics. Thank you.
Thank you so much, Maria. That was really, really interesting. I think one of the first questions that I would like to ask you then is, does this mean then that it's all about the chain of survival being that bit stronger in the hospital environment than in the out-of-hospital environment?
Well, our results point towards the chain of survival elements being important, and I think that that it's more easy to secure these in the in-hospital environment than it is in the out-of-hospital environment.
Yeah. And when it comes then to increasing the number of witnessed arrests, particularly in hospital, what type of practical measures would you suggest would be needed in order to achieve that?
In the in-hospital environment? Well, maybe it would be about identifying the patients that are mostly at risk of getting a cardiac arrest, and then making sure that their cardiac rhythm is monitored throughout their hospital stay.
Okay.
Yeah.
And the question that we had during the epidemiology session yesterday was about the definition of cardiac arrest in hospital. And Lars Anderson had described that sometimes patients who have a pulse are actually included as cardiac arrests in hospital. Do you have any ideas about how we should define cardiac arrest in the hospital environment?
Well, in our study, we obtained data from a registry called Danarast, and they have their own definition of cardiac arrest. And we have also excluded the patients with an initial pulse generating rhythm, okay, which would ensure that we don't include these patients in this particular study.
Okay. I think that's what I enjoyed most about your presentation, Maria, was it was another reinforcement of the value of looking after every link in the chain of survival. I don't have any additional questions unless the other moderators have.
Yeah, I have one question. Maria, thank you for your presentation. What we discussed in our hospital is not to search or look for the people at high risk. They're normally on ICUs or some other monitored wards. There was an idea of monitoring the normal ward patients, maybe with an iWatch or something else, variable, to really detect the unexpected cardiac arrest. So young people with an pulmonary embolism after a normal treatment. Are there any ideas dealing with this low-risk patients, but they're also having cardiac arrest?
Well, it's not something we have discussed in particular in my group, but I think the idea about having some sort of watch or something like that to monitor the cardiac rhythm is really good also in patients that are admitted to the ward.
Thank you.
Excellent. Thank you, Maria. Thank
you.
So we'll hand back over to Franziska to introduce our next speaker, please.
Okay, so our third speaker will be Dennis Rupp from the University of Marburg in Germany, and he will tell us something about do not resuscitate orders in hospitals in out-of-hospital cardiac arrest. Okay.
Hello, my name is Dennis Rupp. I'm a paramedic working for the German Red Cross. And in the next few minutes, I will talk to you about do not resuscitate orders in out-of-hospital cardiac arrest, especially about the incidence rate of orders, causes of non-compliance, and consequences on patients. Everyone in the pre-hospital setting knows the situation that you go to a call, find someone in cardiac arrest, and you are confronted with a DNR order. Patients have these orders to avoid CPR and/or limit medical interventions. What we don't know is the rate of incidence of these orders, causes of non-compliance, and consequences of non-compliance to the patients. So what did we do? We investigated all calls with CPR attempts by EMS of patients with the age of 18 and older in the county of Marburg-Biedenkopf. We reviewed the medical report and determined the cases with a DNR order presented to EMS at any time during the call. We identified the reasons for non-compliance and we identified the primary outcome of the patients. Over the investigation period, 456 CPR attempts by EMS were recorded. A DNR order was presented in 76 cases, which means 16.7%. The age of patients was 79.3 years, and we had some more males than females in our group. The arrest was witnessed in 64.5%, and the bystander CPR was performed in 61.8%. The duration of CPR by EMS in the cases with a presented DNR order was 60 minutes 11 seconds in median. As already shown on the slide before, a DNR order was presented to EMS members in 76 cases. Among these patients, any kind of airway management was performed in 56 cases, which means insertion of a laryngeal mask or endotracheal intubation. Epinephrine was administered in 45 cases, and in 14 cases any ROSC was achieved. 7 patients were admitted with ROSC at a hospital. But we didn't only wanted to know what kind of procedures were performed and what the outcomes of the patients were. We also wanted to know how the EMS members handled the situations and what causes for non-compliance existed. We found out that in 27.6% resuscitation was terminated early after arrival, which means before any ALS procedures were performed. That means that family members showed the DNR order to EMS really early. In 17.1%, the question for an existing order was asked after performed ALS procedures. So an airway management was done, a vascular access was established, and epinephrine was administered. In 15.8%, the EMS members asked for an existing DNR order after more than 30 minutes of CPR. So maybe that was the time where they thought about termination of resuscitation, and then the question for an existing order came into their mind. In 14.5% of the cases, the relatives didn't remember that an order existed. And in 2.6% of the cases, the existing order shown to the EMS did not meet the criteria of the case. So what can we conclude? We can say that EMS teams are confronted with the DNR order in 1 of 6 cases of CPR. In the early phase of the call, it seems very difficult to check the order. ALS procedures are performed in more than 50% of the cases. And sometimes asking for an order seems not in personnel's mind. So we suggest the question for an existing order should be fixed within the guideline protocols to remember EMS and meet the patient's will. Thank you very much. For any further questions, send me an email to the shown address.
Dennis, thank you for your presentation. Really interesting data. And before I start with the first questions, I will encourage all the participants of this session to send via the Slido system their questions to us, so they can be answered. So if you forgot how to do, try it again. So it's very easy. And while we are waiting for questions from others, I will start. I was impressed by your data that you say that you have 64% witness CPR, witness cardiac arrest, and you have 61% bystander CPR rate. This is for every case in your region, or is it for the patients with the DNR order?
These are the numbers for the patients with the DNR order, but there's no significant difference to all the arrest situations. So the bystander CPR in our region is extremely high because of a standardized telephone CPR by the dispatchers given to the caller.
This will bring me direct to the next question. So the relevants call the EMS, talk about cardiac arrest, get an instruction for bystander CPR by the telephone dispatcher, and started CPR in 60% on people that have a DNR order.
Yeah, right.
Okay, and I think this is some of the difficulties that the EMS person then comes to a situation where in more than half of the cases, someone started CPR. So maybe they don't think about this DNR order. It sounds a little bit crazy that people start CPR when they know about the DNR. But now we have some questions from the audience, and I'll check it. Talk has been any changes made in your local practice? Okay, the first question comes, I will put it in the audience, is after you know that now, have you changed your protocols and your treatment at your local EMS system?
That's an easy answer. No, we didn't change anything so far.
Okay, second question, but it's very easy to answer. Please come up with your email address again. People want to contact you directly, so maybe we have to do this at the end. Next question. Okay, this was the last slide. So, okay. Do you use, this is a good question from Franziska Wagner, do you include now asking for a DNR order in your training, in your simulation? So is it a part of your annual CPR training now asking for a DNR order?
Not so far right now, as you have seen the data set was evaluated right until the beginning of the COVID pandemic situation. So after that, we interrupted our continuing education for EMS personnel. And but that it's really a point that we have to keep in mind for restarting our training.
Okay. And I think this is also very interesting questions coming from Attila Eros. He asking, was there any case where the EMS did not comply with the DNR order? So they say unbelievable, too old, so they saw it and ignore it actively.
As shown on the slides, we had a lot of cases where the question for an existing order was already asked very late. But we also had 2 cases where the EMS team decided to meet the will of the relatives that were present on the scene as the patient's order. So the patient's order was did not find any consequences, and the will of the relatives they were present were met.
Jan Thorsten, we have one question here from John Newman. The question is, did your research take into account any mitigating conditions in the DNR? So I think that means, did your research account for any special conditions or particular conditions that happened that would have affected whether a DNR could be used or not?
The limitation is that we only know from the cases that were reported in the medical report of the call. And so sometimes the whole situation is not very good documented. But I would say no.
Okay. And I had just one last question myself, Dennis. Like your research is so interesting, and to think that 1 in 6 patients had a DNR, but yet had a very active resuscitation attempt. Do you have any ideas about how we might make sure that DNRs are acted upon before resuscitation is started or at a very early stage of resuscitation?
I think that's a very difficult thing. In the early phase of a CPR, especially here in Germany, where you only have the paramedic staffed ambulances, and you arrive on the scene with only 2 people. So you would have to decide really fast if you start CPR or ask for an order. So when the physician unit arrives and the call is you are working and everything is going routinely, so that would be the time to ask for the order. So I can really good understand that we found out that in many cases ALS procedures were performed because you don't have the time to look for.
Yeah, understood. Good question or good answer, thank you. Brilliant. Franziska, we'll let you introduce our next speaker.
Right. Since Dr. Terry Brown unfortunately is not in this session, we will not hear the 4th and the 5th presentation. That's why we will directly skip to Mahina Charan, working in the University Hospital of Southampton, and tells us something about the in-hospital cardiac arrest audit. Afterwards, because of the time we have left, we might discuss a little longer if we would like to.
Hi, my name is Mahina. I'd like to thank the ERC Congress for giving me this opportunity to present an audit on looking at in-hospital cardiac arrest outcomes for patients admitted to Southampton General Hospital. So to start off, I'll just show us the study population that we were looking at in this case. And we were looking at patients admitted between 2017 and 2018. There were just under 150,000 total hospital admissions that year, and 116 confirmed cardiac arrest during that time period, of which the majority occurred on the ward, but a smaller proportion as well in a level 2, level 3 care setting. We were interested in looking at the patients who achieved ROSC post-cardiac arrest on the wards, and of these patients, 19 remained on the ward and 35 went to an intensive care setting. These are the patients who remained on the wards post-cardiac arrest. So, as you can see, the past medical history is quite varied and includes conditions like malignancy, stroke, chronic cardiac disease, amyloidosis, and also COPD as well. The age group is roughly over 75 and above, and the most common admission diagnosis was pneumonia, but also includes, as you can see, heart failure, acute coronary syndromes as well. Few of these patients had a cardiac arrest shortly after their admission, but for the majority of cases, the patients were in for a few days before their cardiac arrest. Of those patients that did achieve ROSC on the wards, unfortunately, majority of them died within 24 hours of the initial cardiac arrest event, with only 2 patients being discharged successfully. The most common cause of death being pneumonia in these cases, with, as you can see, a wide variety of contributing factors mentioned in 1B. Of the patients that went to GICU, there was a total of 14 patients with an average age of 68, median length of stay of 6 days, and of these patients, majority of them had no discussion about escalation decision making prior to the arrest, and almost all of them did have discussion with families after the arrest. Fortunately, the survival to discharge was very poor and no patient survived beyond a GICU admission. These are the characteristics of those patients, and as you can see as well, a wide variety of past medical history, slightly younger age group, more so in the late 60s, early 70s, with also a wide variety of admission reasons, ranging from pulmonary embolism to pneumonia to sepsis. Few of these patients had a cardiac arrest shortly after their admission, but some of the patients were in hospital for a few weeks. They were all intubated, ventilated, bar one patient, and all of them had a do not resuscitation discussion with their families within 24 hours of their GICU admission. And unfortunately, the majority of them also didn't survive past 48 hours from their GICU admission, with causes of death being mentioned, including multi-organ failure, acute myocardial infarction, and hypoxic brain injury, to name a few. Of the patients who went to cardiac intensive care, the outcome was far better. 90 patients were admitted after achieving ROSC on the wards, and only 5 patients died, the most common cause of death being cardiogenic shock, and the survival discharge being 73.6%. So overall, if you're younger, you're far more likely to survive. The cardiac arrest was often a trigger to think about escalation decisions. And if you had a cardiac cause, you were far more likely to survive. And interestingly, almost 20% of patients were noted to have repeated admissions that same year. So overall, advanced planning is absolutely the key take-home message here. If we can involve these patients in their decision-making and escalation plans prior to cardiac arrest events, then that is a far better way of improving hospital outcomes from in-hospital cardiac arrest. And these should be done when the patient has the capacity to do so, and they also have the support of their families as well. Once they're intubated, ventilated, it's too late to think about these things, and decision making can be done in a more timely manner. The factors listed here are things that could be that should be included in that decision making process, including the age, comorbidities, and reason for admission and functional status. For this reason, the Trust has included a treatment escalation plan, which hopefully will help identify those patients who might be at risk of cardiac arrest and severely unwell, and introduce some escalation decision-making triggers for clinicians and other healthcare professionals. Thank you very much, and I look forward to your questions.
Thank you very much, Mahima. That was a really good presentation. Francisca, have you got a question there for Mahima, please?
Yes, Mahima, thank you very much. I would like to know how the treatment escalation plan is accepted by the patients.
Yeah, so what's interesting is in terms of the treatment escalation plans, we're yet to do another review of how that is being dealt, but this was rolled out within a month of this initial study. what's interesting is that a lot of people are more versed to their medical needs now. Now, if you look at the patients that had cardiac arrest, a lot of them have comorbidities. There were very few that were actually very young with no comorbidity. So these patients have had a thought process in terms of what they would want and what their healthcare requirements are. And actually, of those 14 patients that went into general intensive care to the ward, a lot of the families came to us, and I didn't have time to show this in the study, and said they wouldn't have wanted this to happen to them. They would have wanted to have a chat as to what ITU involves. And as you can see from our speakers today, an ITU admission is no mean feat. They have a lot of patients don't understand what intubation is. They don't understand critical illness myopathy or the psychological effects of it. So actually, Southampton's actually doing very well. If you actually look, there's only 116 confirmed cardiac arrests with 150,000 admissions. So we're doing something right. But obviously those 14 patients and the ones who are in cardiac is difficult. So a lot of people actually feel that asking the simple question, what would you like us to do for you if you were to become unwell, has been taken quite well and is not met with any difficulties. What's really interesting is 20% of these patients had previous admissions, and that in a way could possibly be assumed to be a marker of mortality and morbidity. So I think it's been well received by most people, actually. Yeah, sorry for the long question.
We do have one question from the audience here from
Yeah.
Barney. The question was, did any patient admitted to GICU receive any form of targeted temperature management?
Yes, so all of these patients had a standard post-resuscitation care with temperature targeted management. And what's really interesting is we know that we're supposed to neuroprognosticate at least for after 72 hours. And what was quite striking is in the patients admitted to general intensive care, as you can see from the individual data, a lot of those patients actually developed multi-organ failure and didn't even get to the 72 hours of neuroprognostication. So we could do those. So none of these cases were withdrawn on before that time. We gave them the appropriate time as per the ERC Resuscitation Council guidance. So this is quite striking in telling us that actually a lot of the patients didn't get to that time, and all the standard protocols were followed by our team in the ITU department.
Okay.
So
thanks, Mahima. We have a few questions here now. We have one from Céline in Ireland. Great presentation, thanks. Did or would you consider patients from ED departments whilst they were waiting for admissions to the wards? Were they part of your cohort?
So they weren't specifically part of the cohort, actually. We were not more interested, but there's the ED department did have their own protocols of how they do cardiac arrest and have their own separate system, which is quite interesting. We were focusing on the patients who are on the wards, as they actually make the far higher proportion of in-hospital cardiac arrest. And in terms of the definition, please educate me, a lot of the patients that come into ED are actually out of hospital cardiac arrest, with very few actually occurring while in ED department. So yes, that is something to look into, but we were focusing on the wards specifically.
Okay. A few more questions for you, Mahima. Dr. Taran, thank you for your great talk and highlighting the importance of escalation and treatment plans. So I think that's just a comment rather than a question.
Oh, thank you.
And from Juliet Ann Hendrick, are you using the RESPECT document in your hospital in support of decision-making and escalation?
What was that, sorry?
Are you using the RESPECT document?
We're not using that specific document, no. The treatment escalation plan form that I discussed was part of the initial process of improving these discussions, but that is something I will forward on, actually. I will look into that. So thank you for sharing that.
They keep coming here, Mahima. John Newman would like to ask you, to what extent does this study distinguish between unexpected deaths and those on end-of-life plans?
So of all the patients that are on, as part of the hospital policy, if you are on end-of-life care pathway, you will have a do not resuscitation discussion and escalation plan done as part of that process. So all the patients that you saw were not on the end-of-life care pathway, and majority of them did not have any do not resuscitation discussions before that.
Okay, Okay, and another question from James Nicholson. Did the audit suggest particular factors that might help predict duration of survival in the GICU ward population within this cohort?
So as unfortunately, it didn't tell us exactly, because of the various varieties of reasons why people had the arrest in the first place. There wasn't any clear defining factors that I can say that would more likely predict a good outcome. What we do know, and this is well versed, that if you had a cardiac cause, you're far more likely to have a favourable outcome than if you didn't, and that is nothing new that has been discovered. That is well versed. So unfortunately, I can't comment exactly on that.
Okay, thank you very much, Mahima.
Thank you.
Okay. Jan Thorsten, did you want to comment there on, we haven't had Terry?
Yeah, so it's a pity that Perry jumped in late and we saw some conversation on the chat channel. So he arrived late, and as he decided to continue, there was no time to see his presentation. Now, on our material, I think you can hear us. So everyone is invited to look on the online platform and to look at both presentations from him. And as I said before, please send him an email when you have questions, and it would be a pity if you missed that slide. So please join and use the web page and see Terry's presentations.
That's brilliant. So we still have some room for questions if anybody would like to add any to the Slido. But if everyone wouldn't mind just putting on their videos for a moment. There was a few questions that I had for the panel. I was just start with Johan. I was really interested in your presentation about the health index, and before the presentation started, I had asked you a bit about whether the health index was in regular use in Sweden, but I understand that it's not just at present. So have you any ideas about how the health index might be put into everyday use for patients who have survived cardiac arrest?
I think we can use it in regular cardiac arrest follow-up in hospitals. That's one example. I also think it's possible to put it in registry follow-up. We have similar measures today, like the Eurocall 5D, 5L, hospital anxiety and depression scale within the registry follow-up. So might be an alternative to include a health index as well.
Okay. And it was really interesting that the results of the health index suggested that the overall health of survivors was not much different to the general population. So does that show you that a reported outcome will be reported in a relative way, that you would expect people who have gone through a cardiac arrest to have perhaps worse health than the general population, but they in fact themselves did not judge that to be the case?
Yeah, it looks like when they report themselves, they think their overall health and quality of life is acceptable or good, but we still see that the variation is huge, and we can find health problems in this group. So we need some measures to find these health problems to be able to give them appropriate support.
Yeah. Okay. And I think we have a question here from Marikia to Dennis. A question for Dennis, very interesting topic. Do you have data on whether the person who made the emergency call was aware of the DNAR?
So am I right? The question is if the callers were aware of the arrest situation.
I think it's if the person who made the call about cardiac arrest was aware that the patient already had a DNR when they rang the emergency number.
I don't know, but I think in most situations, the people that call EMS are not aware of the really arrest situation. I think they get instructions via phone from the dispatcher, and I think they are not aware what they are doing at this moment.
That makes sense. And I suppose I had one kind of general question to all the speakers, because we haven't had a COVID related question yet. So we must have a COVID question for every session. And it's, I suppose, my question would be, around, one of the first questions would be around advanced decision making and DNRs. I suppose specifically to Dennis and Mahima first. Has advanced decision making changed in your workplace during the pandemic?
Thank you. That's a very good question, and it definitely has had an impact. So I do feel that I think there was some data talked about yesterday in the in-hospital cardiac arrest, but from the Resuscitation Care UK session, and there's already emerging evidence, though we'll have to look at the final numbers, that the number of cardiac arrests during this COVID pandemic time is predicted slightly lower than we would expect, which is quite interesting. And I think maybe an effect of this pandemic overall would be, in a way, these discussions regarding do not resuscitate and also and escalation, because these two are different things. Do not resuscitate is privy to a discussion on cardiac arrest, whereas escalation, that doesn't necessarily mean you won't give someone, say, an IV or level 2 care. So I have definitely noticed a reduction in the number of cardiac arrests, though not objectively, I can't give numbers, but subjectively, yes. And maybe this trend will continue and change things, actually, after the pandemic hopefully comes to an end.
And in Germany, Dennis, what has been your experience in the out-of-hospital setting?
What I can say for our region is that we also have a lower incidence of arrest situations, actually, at the moment, and but we don't have an increasing number of DNR orders or some difficulty in decision making right now, because in our region here, compared to other regions, we have only not so high incidence rate of COVID, and we only have a few COVID patients who needs intensive care at the moment.
And Maria in Denmark, what has been your experience?
Well, since I'm not a physician, I don't have much clinical experience, but it's been my impression that the incidence in Denmark has fallen as well, for especially in-hospital cardiac arrests.
Okay, and Johan, we should hear the experience from your region in Sweden.
Oh, I don't have any objective
just
data
your
on that, but my subjective notion is that we perhaps have a lower incidence in cardiac arrest and resuscitation in Sweden, both out of hospital and in hospital. That's what I think, but I don't have any data on that.
That's okay.
But perhaps the pandemic might help us to improve in making do not attempt resuscitation decisions. So some good will come out of it, perhaps.
So I'll just ask my other panel members if there's any specific questions they would like to put to our presenters.
Not from my side, so I'm really impressed by the quality of the abstracts and then of the presentations. And again, we got contact with Terry, and he is so disappointed that he was not able to join, but he is waiting for questions, and per email you can ask him for his presentation. So I think there's a good chance to discuss also that slides. Perfect. Good. This is from my side, and if there's no additional comment, I give the last word to Franziska.
Okay. So in the name of Siobhan Masterson and Jan Thorsten Gräsner, we would like to say thank you again to all the speakers and non-speakers, Terry Brown, for their hard work in advance. Yes, and we would wish you a great ongoing virtual ERC Congress.
Thanks to everyone. Thank you. Bye-bye.